Hi everyone. We might make a start. So to start off with, on behalf of Yassi and the UCCC team, thank you for coming tonight to our 2022 Information Night. We're pleased to see such a great turnout. I'm Aisha and this is Jacqui. We are the co-directors of UCCC for 2022. Tonight we also have the UCCC logistics officers, Amy, Carly and Christy, and our research officers, Krishnil, Prageeth and Chirui with us tonight. Before we begin, we would like to acknowledge that today we are dialing in from the lands of the Wurundjeri people who have been custodians of this land for thousands of years. We would like to acknowledge and pay our respects to their elders past, present and emerging, and extend this respect to everyone who may be dialing in from different countries. I invite you all to also use the chat function to write a quick acknowledgement of country of your own.
Thank you, Aisha. The University Cancer Case Competition is a branch of the Young Australian Cancer Initiative, which aims to nurture a future generation of cancer-literate students who are empowered with the skills and knowledge necessary to reduce the burden of cancer in our society. The UCCC aims to provide an opportunity for university students to critically analyse the state of cancer research, prevention and treatment in today's global society. We would like to thank our main partner, Liverwell, as well as the partners of Yassi, Burnet Institute of Medical Research, Cancer Voices, WeHi, Peter MacCallum Cancer Centre, and Cancer Council for their support. Now we'll introduce the theme for UCCC 2022, Viral Hepatitis and Liver Cancer Awareness. Liver cancer is the fastest growing cause of cancer death in Australia, and the 9th most common cause of cancer-related mortality. Prognosis is poor, with just 18% of people surviving to 5 years after diagnosis. Alcohol abuse, obesity, and smoking all increase the risk of developing liver cancer. In Australia, chronic hepatitis B and C infections are significant risk factors for primary liver cancer and are estimated to affect more than 350,000 Australians. Concerningly, projected treatment uptake for both hepatitis B and C falls short of Australian targets set under the 2018 and 2022 National Hepatitis B and C strategies.
Now for your task. So your teams are going to assume the role of a group working for the Australian Government's Department of Health and Aged Care. Your team has been tasked to develop a proposal to improve early detection of potential liver cancer in people with chronic viral hepatitis as part of a broader aim to reduce the incidence of liver cancer in this population and improve outcomes. This will help put the Australian population back on track. The PBS has allocated resources for an intervention to help put Australia back on track to reach these targets. So your task is to develop a proposal that will increase early diagnosis and treatment of liver cancer amongst people with chronic hepatitis infections. You guys have been allocated a budget of up to $10 million and a timeframe of up to 5 years to implement your proposed solution. Okay, so to give you guys a well-rounded overview of this topic, we have an esteemed guest speaker panel from Liverwell and Burnet Institute to present tonight. Before we begin though, we'd appreciate your feedback on Info Night 2022. So if you could please fill out this evaluation survey during the event, that would be really, really great. Everyone who completes it will be entered into a raffle for a $20 Uber Eats voucher to be drawn at the end of the night. And we'll flesh out these competition rules, key dates, and have time for any questions at the end of tonight as well. So make sure you stick around.
Let's get started with our first presentation. I'd like to proudly present our first speaker. Chloe is the Health Promotion Manager of Liverwell. She will talk about community education, minimizing risk of progression of liver disease to liver cancer, and the importance of informed healthcare provision and the impact of stigma and discrimination.
Thank you so much for having me. I'm Chloe Pedley. As Christy just said, I'm the Health Promotion Manager at Liverwell, and I'm very excited to introduce you to Liverwell and the work that we do to prevent cancer by advocating for people living with or at risk of viral hepatitis. And I'm joining you tonight on the lands of the Wurundjeri people of the Kulin Nation. And I'm just going to share my screen and we will get started. So I'm really excited about this health promotion competition that you're running. I think it's a fantastic initiative and I'm looking forward to seeing the ideas that come out of it. There we go. So who is Liverwell? We are a small but mighty organisation that champions the interests of people living with or at risk of viral hepatitis or liver disease. We've been doing this work for the past 30 years, which is longer than some of you have been alive. We work to reduce stigma, provide community leadership and provide advocacy. And we do this with a number of programs, including outreach work and education programs. Why do you have to care about this? There is an estimated 335,000 people living with hepatitis B or C in Australia. Worldwide, viral hepatitis is responsible for 1.4 million deaths per annum. Scarily, 9 in 10 people don't know that they have hepatitis B or C, and stigma and discrimination continue to marginalise and isolate people. So liver cancer, as I think it was, wasn't Jacqui? As it was just mentioned earlier, liver cancer is the fastest growing cancer risk in Australia. It is impacted by lifestyle and behavioural factors such as alcohol, diet, physical activity, tobacco smoking and unsafe sex practices. And that information is pulled from the Australian Institute of Health and Welfare. Liver cancer is the fastest growing cause of cancer death in Australia, the fifth most common cause of cancer death in males and the 8th most common cause of cancer death in females. Unfortunately, this is even higher for Aboriginal and Torres Strait Islander populations. Viral hepatitis is a major cause of liver cancer, and as you'll see in the next presentations and slides, it is eliminable. So, viral hepatitis and liver disease are a progressive disease. It starts with inflammation, it moves to fibrosis, it moves to cirrhosis over time, and eventually to liver cancer. Most liver disease follows a similar path, beginning with inflammation and moving through this progression. And Jacqui will be covering this in much more depth. I work on the community side of things, and you are so privileged to be able to listen to Dr. Jacqui Richmond this evening. In very brief information, hepatitis C is caused by the hepatitis C virus and is transmitted by blood to blood. The great news about hepatitis C, if there is great news, is that it does have a cure. Hepatitis B, on the other hand, is caused by the hepatitis B virus and is transmitted blood to blood and sexual fluids. There is no cure for hepatitis B, but there is a vaccine and very effective treatments. Now, this slide tells a bit of a story, and it's taken from the Doherty collaborating with the World Health Organization viral hepatitis mapping project. And it shows where there are some big gaps in care. So there are 222,559 people living with chronic hepatitis B. Of them, 73% are diagnosed and 27% are yet to be diagnosed and moved into care pathways. Of those diagnosed, there are 22.6% in care and 77% not yet engaged in care. Then approximately those 20% of those in care need treatment, and half of those people don't receive treatment. So as you can tell from this cascade, there is a lot of work to be done in terms of advocacy, education, destigmatization. People don't engage with care for many reasons, but a key reason that we see on our liver line service, our info line service, is fear and stigma and the perpetuation of the myth of the healthy carrier, which leads people to believe that they don't need to check in with their hepatitis B status until well into their 40s. This is, of course, a myth, and hepatitis B needs to be managed early to prevent the progression, however slowly, of the disease. Then we talk about hepatitis C. So hepatitis C affects 115,000 Australians, and 1 in 5 Australians with hepatitis C remain undiagnosed or unaware of their infection. In Victoria alone, 40,000 people are living with chronic hepatitis C with a treatment uptake of only 55%. Now, to drill that home, there is a cure for hepatitis C, and there are many reasons that people don't take up this cure. People not knowing their status, self-stigmatization and the belief that they aren't deserving of treatment, loss to follow-up in care for a huge number of reasons, and the belief that the cure for hepatitis C is still the old interferon treatment. There are also priority populations that are difficult to reach with hepatitis C treatment, including people experiencing homelessness, people using drugs, people in mental health care settings, and Aboriginal and Torres Strait Islander populations. So while it seems very simple to say, get cured and prevent cancer, the problem is nuanced and very complex. Now I'm going to let you read this slide. It speaks to, it's from the Vital Voices for Hepatitis C project put together by Dr. Adrian Farrugia, and I highly recommend you check that out as part of your research in this project. It talks about the lived experience of hepatitis C in particular. This particular individual didn't disclose their hepatitis C to their family because of their fear and the fear of stigma, which I think is a very powerful statement. So how do we do what we do at Liverwell? We have a free and confidential liver line. This is one of our key health promotion strategies. People dial in and get liver advice from our community educators that is staffed by our health promotion and community and engagement team. We produce resources to support people living with viral hepatitis and liver disease, and we have a fully stocked resource room of material that we send out to organisations and individuals. We have some of those resources translated in language to Vietnamese, Chinese, Dari, Cambodian, and a number of other languages. And one of our key activities is that we run education sessions to workforce and community groups. These education sessions focus on upskilling people to understand hepatitis B and C, the care pathways, and the challenges involved in getting people into care from a community perspective. These education sessions are tailored to people in the alcohol and other drug sector, people who interact with the justice system, particularly people who are in the post-release forum, and Aboriginal and Torres Strait Islander populations, young people, and our workforce-specific training, HEP Ready Essentials. So there is work to be done with stigma, and healthcare professionals have such a key part to play in this. Stigma is a mark of shame or discrimination, and it comes from many places. It might be healthcare professionals treating people differently or othering their patients. It might be family members insisting on isolating their family members who are living with hepatitis B. It might be self-stigmatization or the belief that one isn't worthy of treatment. Stigma prevents people from getting into care, staying in care, and as a result can perpetuate a huge range of consequences that can lead to liver cancer. So what can we do and the work to be done? There is work to be done to address stigma and discrimination, and it begins with you, the healthcare professionals. Treat everyone with equity and respect. Assume that everyone is at risk of viral hepatitis. I'm personally a huge advocate for universal screening with consent and frank conversation. And the discussions mean that no one falls through the gaps. Educate yourself on viral hepatitis and how to break through the shame and stigma, and how to treat everyone with equity and respect, and constantly check your assumptions and biases, because there is no one key source of truth when it comes to hepatitis B and C transmission and the types of people who are impacted by liver disease. Resources that might get you started on your project. We've got the Liverwell app, which is absolutely fantastic. It allows people to manage their appointments, to track their medications, to keep a track of their health notes and to write notes in it. It also connects people to our liver line. Our liver line, 1-800-703-003, is a great resource for people at risk of or living with viral hepatitis and or liver disease. We have in-language resources, and we are always happy to run education sessions for organisations who work with people at risk of or living with viral hepatitis. And that brings me to the very end of my presentation. So I'm going to stop sharing my screen now, and I welcome your questions in question time.
I'm sure you found Chloe's presentation helpful in developing your understanding of health promotion for liver cancer. Next, we'll hear from Dr. Jacqui Richmond from the Burnet Institute. Dr. Richmond is a program manager for the workforce development and health service delivery component of the Eliminate Hepatitis C Australia Partnership. Jacqui has worked in the viral hepatitis sector for 20 years in nursing, education, social and health service research, and policy development. The broad focus of her work is building the capacity of health workforce to test, treat, and manage the healthcare needs of people living with viral hepatitis.
Thank you very much, Christy. I'm just going to share my screen. Thank you, Chloe, for setting it up so perfectly. I am also utterly thrilled to be here, and I am very grateful to Liverwell for the invitation to join them on this journey. I have been trying to get to you guys for decades, you guys being undergraduate students, our future healthcare workers, the people who are going to take us to elimination of viral hepatitis, which is our target by 2030. So I am absolutely thrilled to be here. I love that you're doing this topic, and I avail myself to any of you to support you through this process, because I just think it is so wonderful to see young people taking such an interest in something that we can, in one case, hepatitis C, we can cure it. We can get rid of it. Hepatitis B, we can prevent it. We don't need to have people living with hepatitis B in this country. So I'm going to go on a pretty whirlwind rapid tour. I get very excited about viral hepatitis. So I do invite questions, probably in the chat. I often go for long periods of time without breathing. So don't wait for me to take a breath if there's something really urgent. I have been working in viral hepatitis now for over 20 years, which is a little bit terrifying. When I first started, we certainly had no idea we would be curing one and aiming for elimination. So I would like to begin also by acknowledging that I'm presenting today from the lands of the Wurundjeri people of the Kulin Nation and pay my respects to elders past, present and emerging. And most importantly, acknowledge that Aboriginal and Torres Strait Islander people are overrepresented in the populations living with viral hepatitis B and C, and impacted significantly by liver cancer in this country. We still have a long way to go in terms of closing the gap. So I'm going to give you a brief overview of the liver and then build on what Chloe has already said with regards to Hep B and hepatitis C. So the liver is, I think of it as a size of a deflated AFL football. It sits nicely underneath the rib cage. You can't palpate it unless sometimes you can feel the outer margin of the liver. I have once in my life felt a knobbly edge of a liver, which was a cirrhotic liver. It was much smaller and harder than a healthier liver that I'd felt. It's got two lobes. It's got a left lobe and a right lobe. You can see there the size, and it's approximately 1.5 kilos. The liver is a very important organ, and we will test you on all of these functions in a moment. And I know most of you will be studying this. If you're doing medicine, you will know this inside and out, if you don't already. But it is a very important organ in the body. My mind, the liver is like a factory. Raw materials go into it, and things that we need to sustain life come out the other end, and bad things are excreted. So we're making proteins and albumin and clotting factors. We're breaking down carbohydrates and fats and proteins. We're storing vitamins and ferritin. We're excreting bilirubin, and we're detoxifying through drug metabolism. The organ is it's very unique in our body. It's one of the only organs that has the ability to regenerate, to grow new cells. So it can take a long time for us to see a reduction in the functioning of the liver if there is an inflammatory response going on. So hepatitis is just a general term that means inflammation of the liver. It can be caused by a whole range of things. It can be caused by viruses, infection, chemicals, alcohol, drugs. Now that's over-the-counter, illicit, and prescription medication as well as complementary medicines and herbs. And there are other factors that can cause inflammation of the liver. When we talk about viral hepatitis, we're talking about hepatitis A, B, C, D, and E. When I first started working in this field, we used to have a hepatitis G, and G, as it turns out, stood for good. If you had hepatitis G, there was absolutely nothing wrong with your liver. If you had hepatitis G and HIV, your HIV didn't progress as fast. So G, not a bad guy at all. So left him off the bad guy list. And hepatitis F appears to have been a bit of a mistake. So we are stuck now with these 5 very different viruses. So they're different RNA, DNA viruses. The only thing these viruses have in common is when they enter the body, they all get there in different ways. When they enter the body, they travel to the liver, and that is their preferred site of replication. So very, very different. And people are constantly confused. I'm sure Liverwell get all of these questions asked of them, as I do. If I've got Hep A, does that mean I'm now at risk of Hep B? Or if I've got Hep C, does that mean I've had Hep A and Hep B? They are absolutely different to each other and not related in any way, shape, or form like that. All they have in common is that when they get into the body, they travel to the liver, and that's where they like to reproduce. And as a byproduct of their replication, the body starts an inflammatory response. So we've got vaccines against hepatitis A and B, and as a byproduct of B, we've got a vaccine for D, or Delta, because Delta is a co-infection or a superinfection of hepatitis B. It's not well characterized in terms of epidemiology here in Australia. We don't test for it enough. We're trying to change that, trying to improve the epidemiology and surveillance and notification of hepatitis Delta. But we certainly do know it's a problem around the place. So this is very similar to the picture that Chloe showed. So you've got a nice, healthy liver. You can see it's a good size, it's shiny, it's smooth. When you start having an inflammatory response, so a virus or whatever the etiology is, it creates the body's response to that is to become inflamed. It's trying to get rid of that, whatever it is, that virus out of the body. And we've got these little cells, these, what are they? HSC cells, and I'll show you in a moment. They become inflamed, they begin to respond to that inflammatory response. And that then leads to the activation of complex collagen, which is then deposited. And you start seeing the beginning of fibrosis, or that buildup of that collagen. So you've got chronic hepatitis, then can lead to cirrhosis. So that poor little liver there is not looking very healthy, is it? It's smaller, it's knobbly, and it really is quite affected by, and its functioning is now beginning to be affected. And then you can move to hepatocellular carcinoma. There is a challenge with hepatitis B. The majority of the time, 90% of the time, this is the pathway that it goes. You have a healthy liver, you have fibrosis, you then lead on to cirrhosis, and then that's when the development of HCC, or primary liver cancer, can occur. However, with hepatitis B, this doesn't necessarily have to be the case. And that's why we have liver cancer surveillance based on age. So people at certain ages, depending on where they were born or their family history, are entered into liver cancer surveillance, because you don't necessarily have to have cirrhosis of the liver for you to be at risk of liver cancer, even though that is the majority of the time. So this is where you can see that you've got this build-up over time. So the HSC cells become activated by whatever is causing the liver disease. That leads then to collagen deposits. And then you can see it sort of becomes this scar matrix. So you can have mild liver fibrosis, moderate, and then when you've got severe, this is when you have a cirrhotic liver that looks like this. So putting them side by side, the liver is actually smaller and its functioning is now beginning to be affected. So there is no doubt that hepatitis B is the leading cause of liver cancer around the world. And this is Hep B around the world. So you've got dark red areas representing very high prevalence of chronic hepatitis B. Here in Australia, we look like a green country, a low prevalence country, but we do have red pockets. So certainly in Northern Australia, amongst our Aboriginal and Torres Strait Islander populations, we see high prevalence of hepatitis B in remote communities. And there is some amazing work being done by Jane Davies and the Menzies Institute up in Darwin, where they are mapping and conducting serological testing on all remote dwelling Aboriginal and Torres Strait Islander people in the Northern Territory. So some amazing publications to have a look at. You are actually more likely to be living in remote Northern Territory. If you're living there, you're more likely to be on treatment for hepatitis B than you are if you are living in downtown Melbourne or downtown Sydney. That says a lot about the work that we all have to do in our own backyard. So about 350 million people around the world living with chronic hepatitis B. It's the 10th leading cause of death worldwide and the second most important carcinogen, second only to tobacco in terms of its ability to cause liver cancer. As Chloe's already said, we've got 230,000 people roughly living with hepatitis B, chronic Hep B. 2 million Australians have evidence of being infected. Now, when you get that joy of learning about hepatitis B serology, it's a very confusing and it does, sort of slightly does your head in for a while until suddenly it clicks and then you just don't move your head because you don't want it to come out your ears. But the core antibody is a marker of exposure, and there are 2 million Australians who are core antibody positive and are surface antibody positive. They don't have Hep B, but they've had it. If they ever become significantly immunosuppressed, if they undergo chemotherapy, if they are immunosuppressed for a dermatological condition or, you know, have a course of high-dose prednisolone, there is a risk of reactivation. So we are talking constantly to people in those specialties, medical specialties, about making sure they are testing people for hepatitis B prior to immunosuppression. And a quarter of people with hepatitis B in Australia remain undiagnosed. And yet we have universal screening of all pregnant women in this country. And this is an opportunity that I challenge you to think of, right? Is this an opportunity for us to be also testing partners, testing family members? I believe we have 7 to 8 TB contact traces in Victoria. We have 0 contact traces for hepatitis B and hepatitis C. There is a very easy win there that we could just follow up people who are diagnosed and offer in a supported way further testing and linkage to care. This is hepatitis B and HCC. So you can see here the very close association. So yellow being Hep B, you can see those dark red areas around the world, which are replicated with this very high prevalence of HCC. So we know that hepatitis B is a very significant cause of primary liver cancer. When we're thinking about what to do about Hep B, we have to offer testing. So we need to offer testing to people who are living in those dark red, orange areas around the world. One of the wonderful reasons, wonderful things about Australia is that we are a multicultural community. So we have people that were born in other places and now live here. So we need to make sure that we are offering people wherever they were born, if they were in one of these high prevalence areas, we need to be offering people testing for Hep B. Aboriginal and Torres Strait Islander people should be tested also for hepatitis B. And let's make sure we get the testing right. Liverwell and I spend a lot of time teaching healthcare workers about how to test for hepatitis B. We need 3 tests. We need surface antigen, surface antibody, and core antibody. If we have those 3 tests, we can tell whether somebody has it, whether they've had it, whether they've been vaccinated against it. One of those is not going to give you an accurate reading. We need to vaccinate people. Do you know, a couple of years ago, probably 10 years ago, the Victorian government threw out hepatitis B vaccine because it had expired. And somebody made the mistake of telling me. And I got very, very cross because we should never be throwing out hepatitis B vaccine when we still know that there are people in our community who are not vaccinated against hepatitis B. We need to be offering hepatitis B vaccine because it was and is the first anti-cancer vaccine. You stop hepatitis B infection, you prevent a significant cause of liver cancer. All babies born in Australia since 2000 were all offered hepatitis B vaccine at birth. Adults, it's a course of 3 injections, and we need to make sure that people are being offered vaccine if they perhaps weren't born in Australia, if they are a close contact or a household or a sexual contact of somebody living with hepatitis B. We need to be offering hepatitis B vaccine widely. And there is no point in doing a test if you are not going to link to care. And this point remains the same for hepatitis C. I don't want people testing if they're not going to link people to care. What is the point? So you do a test and then you link somebody into treatment. GPs can manage hepatitis B. They just have to do a short course to prescribe the medication. We have nursing support through Victoria and also around the country where nurses can support doctors, GPs, other GPs, sexual health physicians, AOD, alcohol and other drug doctors to be able to monitor and manage hepatitis B. They don't need to come to a liver clinic. I would prefer people didn't have to go to a liver clinic because parking at hospitals is $25 an hour. And I want these patients to come back every 6 months. I want them to be engaged in their care and in their monitoring. We've got a treatment. It's not a cure, but just like hypertension or diabetes, we can manage hepatitis B. You drop hepatitis B virus and we reduce significantly the risk of liver disease and we eliminate the risk of liver cancer. So there are so many things we can be doing with hepatitis B to reduce the risk.
Sorry to jump in, Jacqui. You've just got 2 minutes left.
Oh, thank you very much. Well done. You got in while I took a breath. So hepatitis C. Look, hepatitis C is, I love hepatitis C, but it's a bit boring these days. 120,000 people living with hepatitis C. That's down, as you can see, from 190,000. We've reduced the incidence, so the number of new infections that used to sit at 10,000, but because we've treated over 100,000 people since 2016, that's when the direct-acting antivirals or the cure became available, we have seen a reduction in the number of new infections that are occurring. So this is what we wanted to see. The Australian government made an amazing announcement at the end of 2015, and they said, let's go and treat everybody. If people get hepatitis C again, because you can become reinfected, we just treat them again. And if people don't really feel very sick, let's just treat them. In other countries around the world, it was only the very sickest, the people with cirrhosis, and once you've been treated once, you couldn't have it again. We are so lucky in Australia that our government took a public health approach to this medication and have said, let's just treat everybody and treat them broadly, and we will see elimination goals being achieved. We are in a situation where we have a problem, however. We've treated the first half of this bell curve. So this is based on the diffusion of innovation theory. We've treated people who knew they had it, were motivated, were not fearful necessarily of stigma and discrimination, or that there was stigma and discrimination, obviously, but it didn't stop them from going into a healthcare setting. Now we're treating the other side of the bell curve. We need people with lived experience to be sharing their experiences. They have far more credibility than a nurse like me. They can bring people to me, and I will obviously treat them with respect. I am a trusted service because a peer or somebody with lived experience has made that introduction. So we need to be going to where the people are. You'll hear about person-centered care. This is what we are doing. So we have nurses around the country who deliver medication to people who are homeless and meet them on a certain corner at a certain time because there's a food van and they know they're going to be there. There are very rarely now do nurses sit within buildings. They sit in vans. They sit out in needle and syringe programs. This is talking about going to where the people are at, going to where people are already accessing some sort of care or having some sort of interaction. And what's really important is a quarter of people diagnosed with hepatitis C in the last 2 years, a quarter of Victorians who developed HCC or decompensated cirrhosis were diagnosed 2 years before that outcome. A quarter. And look at this, they were all in contact with the healthcare system. 99% in the previous 10 years had been to a GP. 60% of them had been to an emergency department. They were having contact with the healthcare system, but they were not offered testing. Nobody connected the dots and said, maybe this person is at risk of a bloodborne virus. Maybe we should be offering them care. So we talk about people being difficult to find. In actual fact, it's us that is difficult to find and difficult to identify who can be trusted, because people, they're out there and they're already in our care. So we need to be making sure that we're offering them that kind of support. I would suggest to you that this data is really old because this is pre-2016. Hepatitis C is certainly not a significant cause of liver cancer anymore. I just couldn't find the data to support that statement, so I challenge you to do it. But this is, alcohol-related liver disease, Hep B and fatty liver disease are the main drivers now of liver cancer in Australia. So I wish you all the very best for this assignment, and I am honestly thrilled to bits. So thank you so much for the opportunity to get into your brains early in your career. Thank you.
Thank you so much, Dr. Richmond, for your great knowledge and insights. We understand that Zoom can be tiring, so we'll be having a quick 5-minute intermission. Next, we'll have Dr. Yap, a medical doctor and scientist with an interest in liver disease. See you then.
All right, welcome back, everyone. So to start the second half of Information Night, we will be introducing Dr. Yap. Dr. Yap is a medical doctor and scientist with an interest in liver disease and also on the Liverwell board. His research focuses on the development of new treatments for liver disease using gene therapy and stem cells. He has broad experience in research and education and across the public and private healthcare sectors.
All right, are you happy for me to start?
Yep, go for it.
Perfect, thank you. Just to double check, can everyone actually see my pointer?
Yep, we can.
Excellent, all right, great. Thanks very much for having me. So I'm just going to give a brief overview of liver cancer, both from a clinical perspective as well as from a research perspective. And now just to start off with, when most of us refer to liver cancer, we're really talking about hepatocellular carcinoma, which accounts for about 90% of all liver cancers found in adults. And this really arises from the main cells in the liver known as hepatocytes. But the liver also has a plumbing system called bile ducts, and cancers can also arise from the cells that line the bile ducts, and those are known as cholangiocarcinomas. And they're much less frequent. They're about 10% of all liver cancer cases, but are also quite deadly. And in children, there's also a specific type of cancer called hepatoblastomas, which arise from very immature cells in the liver. And now we can refer to liver cancer as cancer that arises from the liver, but there's also a lot of cancers that also spread to the liver. And this happens because A, a lot of blood flows into the liver, and number two, for a lot of organs, they drain directly into the liver, particularly things that are gastrointestinal in nature. So for example, your gut drains directly into the liver. So it's the first point where all blood from the gut reaches. So if you've got cancer, for example, colorectal cancer, that's the first place it goes to, because that's essentially where all the blood goes to. That's where all the cancer cells go through. So colorectal cancer that spreads to the liver is very common in Australia. But also, for example, breast cancer that spreads throughout the body, about 50% of those actually go to the liver. And of course, you've got melanoma that can also go to the liver. So those we refer to as secondary liver cancers. And often you find lots of different spots in the liver because that's basically spread throughout the liver. And this is just a very nice picture of the bile ducts that are spread throughout the liver. So again, any cancer that arises from the bile duct can spread throughout the liver as well. So the problem here, and I won't preach to the choir, but is the fact that liver cancer is increasing. So increasing in both its incidence as well as in mortality. And despite being a very, increasingly common cancer and a lot of research going around, the survival rate is still quite low. So it's about 20% 5-year survival rate. And that really has only crept up, it's really improved slowly over recent years, despite a lot of research going on. So really, it's an area of need in terms of coming up with new treatments, in terms of supporting patients, and for us to really understand a lot better. And one of the major problems with liver cancer is the very fact that it tends to affect a lot of younger people, for example, compared to things like dementia, stroke, or heart attacks, for example. And The other thing in Australia is particularly the fact that it affects men about 3 times more than women. So it's a lot of productive years being lost, and it's also a lot of suffering because it is a very difficult disease to treat, and often patients go through a very hard time when they are going through the diagnosis and the treatment. And in terms of the causes of liver cancer, obviously a lot of different diseases can affect the liver. One of the specific things about liver cancer is it's an inflammation-associated cancer. So all of these reasons, so whether it's a viral infection, whether it's a lot of inflammation because of alcohol intake, or whether it's non-alcoholic fatty liver disease, that leads to a lot of inflammation in the liver. And chronic inflammation leads to a lot of changes in the liver, which includes mutations that causes cancer. And that sort of thing can also arise from other genetic conditions, as well as other exposure to chemicals for people who might work in the chemicals industry. But the process itself is quite similar, where there's inflammation that then causes carcinogenesis, and that progressive carcinogenesis then leads to a very severe liver cancer. And particularly in Australia, one of the fastest rising causes of liver cancer is fatty liver disease. And in fact, you can see this steadily rising over time. And this is just a nice picture of one of my patients where they've had a lot of fat infiltration in the liver itself. And just like I said, the biology of liver cancer is pretty similar across all types. So in this case, there's a picture here of fatty liver disease. So there's a bit of fat deposition that is quite common in Australia. So statistics tells us about 20 to 25% of all the population in Australia has some sort of fat deposits, but progressive fat deposit leads to inflammation, fibrosis, and irreversible fibrosis or irreversible liver damage is called cirrhosis. And that sort of very late stage severe change really predisposes patients towards hepatocellular carcinoma. But that can again happen with viral hepatitis, chronic viral hepatitis. It can also happen with chronic alcoholism. It can also happen with genetic changes that leads to a lot of toxic metabolites that are always damaging the liver, for example. But in terms of the biology of liver cancer, we're coming to know about it a lot better. So we know it's associated with chronic injury and inflammation. We also know that the liver itself reprograms itself towards a very immature state. So an immature state means that cells are much more proliferative, and they can also form a lot of dysplastic lesions. And when we say dysplastic, we mean sort of haphazard, disorganized architecture. And that's really the process of cancer formation. We also know that a lot of these liver cancers end up having a stem cell population, and stem cells are important because it means that there's a lot of proliferation. So there's always growth, which is associated with cancer. And this is one of my patients here where you see a lot of cancer stem cells spread throughout the liver. And this is a patient who ultimately ended up with liver cancer. And when we pluck these cells from the liver itself and we do karyotyping, which this is basically looking at all the mutations that you find in the cells themselves, you find it's collecting a lot of mutations that predisposes the patients for cancer. And so why do these patients then get cancer is the fact that these cancer cells can involve the surrounding environment. So it makes its own environment that's fertile for cancer development. So it can recruit things like the stroma. So the stroma are the supporting cells in the liver. The blood vessels in the liver bring blood into the cancer, so it feeds it. And at the same time, all of us are producing cancer cells every day. But the reason why the majority of us, particularly young people, don't get cancer is because your immune system eats it up. But in these cases, the cancer cells actually manipulate the immune environment to actually evade the immune system from detecting it. So all these different considerations come together to form the biology of liver cancer. And in terms of clinical presentation, one of the biggest challenges for clinicians is the fact that liver cancer is often asymptomatic, or it presents in a very non-specific manner. So a lot of patients get tired, particularly when you're working hard and when you're old. You get some sort of non-specific pain in your tummy, but it's often very mild and it comes and goes and nobody thinks it's serious. You might lose a little bit of weight, you might get a little bit of fever, but none of that really tells you that there's something quite wrong with you. So often patients don't go diagnosed until they're in a much more severe stage and the cancer has gotten much more serious. And at that stage, you might get things like jaundice, which is where you might get some yellow presentations in your eyes or your hands, or you might get changes in your belly. And that's really a severe presentation at that point. And so it's really a point of no return. And it's a real challenge for clinicians because if we can actually get patients to be diagnosed earlier, we could actually offer a lot more treatments that will be a lot more successful. So that's a real challenge for a lot of us. So in terms of diagnosis, when there's a suspicion of a patient having liver cancer, what we often do is we first do a blood test. So we look for whether the liver is functioning, and often when there's liver cancer or some sort of damage in the liver, it shows up because the liver doesn't function as it's supposed to. There's also a blood test that looks for a specific protein that's formed by liver cancers called alpha-fetoprotein, and that's a reasonably sensitive way of showing that there is some sort of cancer process going on. And we do a couple of scans. So CT and MRI are probably the most common scans for us to definitively tell that someone has a liver cancer. For example, over here, you can see a nice round lesion in the liver itself. And at that point, it's pretty obvious that there's something wrong going on here. And one of the best ways of confirming that that is actually a cancer is to take a little specimen of that. And that's when we do what we call a biopsy, where we take a needle and we take a little bit of that liver and then send it off to the lab, and someone looks at it under the microscope, as you might see over here, and they do a specific test which tells us whether the tissue is cancer or not. So those are the general processes that we go through in terms of diagnosing liver cancer. So when that unfortunately happens, as with most cancers, the treatment options are quite various. In general, for a lot of cancers, surgery is the one best shot at getting most of it out. But of course, surgery can mean it's a large procedure. It can often mean it's a large liver cancer. So there are other different types of treatments that support or work together with surgery to actually help the patient. And chemotherapy is a long-standing thing that we use for most cancers, but particularly for liver. Sorafenib has been around for the last 15 years or so, and that's been quite effective. But one of the problems with sorafenib is that the cancer eventually becomes resistant. So it works for a while and then it stops working. But increasingly, there are second-line, third-line therapies, including atezolizumab and bevacizumab, for example, which are monoclonal antibodies. And what they do is they target specific pathways, for example, the growth of blood vessels that feed the liver tumor. And those different strategies come together from a drug's point of view to actually combat liver cancer. In terms of radiotherapy, which is often used for a variety of cancers, it's not as commonly used in the liver, particularly because the liver is in your tummy, and if you give radiation, it can affect a lot and damage a lot of different organs. So if we do offer radiotherapy, we tend to have very targeted radiotherapy, and stereotactic means it's very focused. We tend to only give it in a specific area, so we use specific tools to actually target the cancer itself without damaging the surrounding tissue. And there are other techniques, including radioembolization, where we actually infuse the liver or the cancer with radioactive beads. And in fact, this therapy was actually discovered in Western Australia itself. But there are other sort of less commonly used treatments for liver cancer, and we don't offer them to all patients, but when we do, it can be quite effective. And that includes liver transplantation. So forget about giving chemotherapy or taking out a little bit of the cancer, but let's swap the liver for a completely new liver itself. And that's increasing over time. And in fact, about 10% of all liver transplants happening in Australia right now is for liver cancer. But there are also several other tools we can use, for example, called ablation, where we basically fried a little bit of liver that contains the cancer using microwave or using a little bit of ice, so liquid nitrogen. And there's also a pretty fancy technique called transarterial chemoembolization, where we actually feed a little tube directly into the liver tumor itself by passing through all the blood vessels that feed into the cancer, and then we feed it with chemotherapy. So it's high concentration, it's localized, and it's through the blood vessels, so we know that it spreads throughout the entire liver, because basically that's what feeds the liver. So if you stop what basically the fertile ground for the cancer, that's a pretty effective way of actually killing the liver cancer itself. But as a clinician, as a scientist, I'm often quite interested in what's next. So what's on offer? So in terms, other than the standard therapies that we offer our patients, what's on offer? So there are a lot of new drug trials happening right now. There are probably about 6 interesting candidates, but again, progress can be quite slow, and often promising results in the lab doesn't necessarily translate to real clinical results. So that's a bit of a challenge for us here. But there are also very interesting treatments, for example, CAR T cell therapy. So that's actually using T lymphocytes, which are immune cells that have been genetically manipulated to become much more effective for cancer. And that's a simple therapy where these cells are grown in the lab and then you just infuse it back into the patient. So it's like having a blood transfusion, but these are super cells that can go right to the cancer and treat it. So that's increasingly used for solid tumors, including liver cancer. There are other interesting techniques like gene therapy. So we can introduce a specific gene which might actually kill the cancer or slow down growth or decrease blood vessel growth. And we introduced this by injecting a virus or injecting different ways that actually manipulate the gene expression within the cancer itself to treat it. And that's a really new molecular type of therapy being investigated. And as a surgeon, some of the things I'm interested is in the more fancy types of surgery, including how do we actually take as little liver as possible, but effectively remove all the cancer using different ways to, for example, map the blood supply of the cancer itself, or how do we use a robotic platform which gives us better control and some level of automation so we can actually operate in very difficult areas without actually making a large wound in the patient. And also increasingly, one of the interesting areas is 3D printing the cancer in the liver itself. And that lets us play around and plan the surgery before actually doing it. So we can actually do a dry run in the lab along with all our colleagues before we actually do it. So there's a lot of interesting things going on in the clinical space right now. But I'm also in the lab a lot, and I lead a research team that does a lot of research. And some of the very interesting things that are in the horizon for the next 10, 20, 30 years are things like understanding really at a molecular level what causes cancer, what keeps it going, and what are the real targets that effectively kills the cancer. And we can use very sophisticated tools to understand the DNA mutations that are happening, the RNA gene expression, and the downstream proteins that regulate the cancer formation, and how this switches on and off, and how we can manipulate that using drugs, for example, or gene therapy. We're much better at taking little bits of liver, for example, and growing it in the lab. So one of the things that often is a difficult thing in all sorts of research is not having enough human samples to actually research. And so there are new techniques being made to grow little bits of liver in the lab that can actually grow and grow and grow. And we can use that to test a lot of different types of drugs and to use them to actually profile the cancer and to identify new ways to diagnose cancer, for example. And one of the things that I'm interested in is to actually grow a whole new liver from a patient's own stem cells. So similar to liver transplant, where we actually have to get a donor liver, what we're working on is we can take stem cells from blood, for example, that have nothing to do with the cancer, and I can create a whole liver, and I can take out that patient's liver that contains the cancer and give them a new liver back. So that's some of the areas that we're working on. Still a far away from clinical practice, but very promising regardless. So some of the techniques here, for example, this liver, little piece of liver that we grow in the lab from stem cells, and then we can grow it into a liver tissue that's supplied by a blood vessel, and I can transplant that back into the body. And that's a nice big juicy blood vessel that we actually can use for transplants. And so what will the future look like? So one of the things we're all working towards is early detection. So that's the biggest problem with liver cancer. So we can detect it early using more sensitive tests that don't necessarily need something like a biopsy, which can be painful or invasive. We can do a blood test, more blood tests that are more accurate, looking at things like what is the liver cancer shedding into the blood, for example, different stem cells or different markers, and can we analyze that to figure out whether a patient is at risk of having liver cancer, or has liver cancer, are they responding to treatment, or has it come back? So it gives us much more information than the current tests that are available. We're looking at things like more types of imaging so we can get more information and more detail in our imaging. And artificial intelligence is a method for us to be able to diagnose quicker and more reliably. So it's not me versus my colleague in America or UK, but everyone uses a standardized platform that automates the diagnosis program and can be much more effective and much more quicker. One of the most interesting things are personalized medicine. So instead of looking at cancer for all patients being treated in a simple format, it's looking at what are the molecular drivers of that cancer, that patient's cancer, taking a little bit of that cancer and growing it in the lab and testing all the different drugs and the things that can target that mutation and finding out a tailored treatment for that patient's cancer and looking at the evolution of that patient's cancer. And if, let's say, for example, it mutates again or it comes back after time, being able to then specifically tailor the treatments for that patient according to what works, as well as what they're least likely to react to or to have a side effect to. So those are the treatments that we're working towards in personalized medicine. And some of the very interesting new types of treatments include gene therapy that I talked about, looking at bioengineered liver replacements, for example. So there are really new and creative ways of looking at liver cancer as opposed to the current or traditional way of cancer, chemotherapy, and radiotherapy. So as a clinician and a scientist who treats patients and also researches in the lab, I think all of us are working towards a future where we're looking at decreased overall incidence, so much reduced liver cancer than the current rate. So we're actually turning the tide, so it's no longer a increasingly common, but a much more rare type, by focusing on the root causes of liver cancer. So things like viral hepatitis treatment, for example, looking at obesity and diabetes crisis, or for example, looking at patients who have alcoholic disorders, for example, and for genetic disorders, how do we treat genetic disorders and prevent liver cancer? That will really help in decreasing the overall incidence. And in terms of patients who have had liver cancer or have liver cancer, we are focusing on the quality of life, so early detection, early treatment that is minimally invasive and much more targeted, so less side effect profile, much more effective and much more suitable for that specific patient. And overall, we're really looking at improved survival outcomes, so high cure rates for patients who have liver cancer and long-term survival. So cancer is no longer looked at in a traditional manner where it's looked at with dread. So, referred to as things like emperor of all maladies, or interestingly here, this is the Queen Pharaoh of Egypt, who was, this is the mummy that actually they found liver cancer and diabetes in. So, in those times, liver cancer and cancer in general are looked at as dread and a death sentence. But increasingly, even though it is a long winding road, we are all working towards a future where cancer is no longer a death sentence, but a manageable disease, or even something that is something that we can overcome. So I'm looking very much forward to it, and congratulations to everyone who's involved in this. And I really congratulate you for all the efforts that you're doing. Thank you.
Thank you so much, Dr. Yap, for sharing with us. Next, we will be playing a video of an interview with David that outlines his experience, including being 18+ years cancer-free. David is passionate about informing people about hepatitis and liver cancer. He is currently working on several projects, including being the community representative on the Roadmap to Liver Cancer Control in Australia project, which is being run by the Daffodil Centre from Cancer Council New South Wales and the University of Sydney.
When I was diagnosed in 1993 with Hep B, I was very lucky that they even checked for it, because I'm in a rural area, and fortunately my local GP had recently attended a upskilling session with a gastroenterologist about hepatitis. And because I'm not in any of the high risk groups for Hep B or Hep C, and I had been vaccinated for Hep B, it's lucky that he thought to check for it. Turns out the vaccination hadn't worked, and in fact I did have Hep B. Big surprise. I hadn't had the test to confirm that my vaccination had taken, and so I would advise anyone who's having the vaccination to go ahead and have the test and check that it's actually worked for you. My initial treatment was just adjusting to a lot of fatigue and a lot of monitoring. There were, lots of ultrasounds and blood tests and stuff like that. I also adjusted my work to fit in with the fatigue, and gave up some postgraduate studies that I was doing at the time. So I rested a great deal. Some things that I wish I'd known at the time. Well, I wish I'd known how important it was to check that my Hep B jab had worked. Things changed though when my liver function tests worsened and my fatigue certainly wasn't improving. And so it was decided to try me on a 6-month course of interferon. And I have to say, this was a pretty revolting time. I felt a lot worse while I was on it, and lost a lot of weight. And that's when my wife famously decided to christen me the walking cadaver. And the worst thing of all was that when it was over, I was actually worse, and all my readings and everything worsened. So I remember being very down for 2 or 3 days at that time before we talked about it and decided that, let's do the things we could control. So that was rest, diet, exercise, and the famous liver cleansing diet, which which we went on, and I thought we were both on it, but I did later discover that Pauline, my wife Pauline, was sneaking in next door to eat things that weren't on it. But anyway, good on her that she got through it, and so did I. Then late in 2001, antivirals became available for me, and these had the most astonishing effect. I'll lean back a bit. These had a really immediate clinical effect, so that I remember one of my readings that was 660, whatever that was, one of the liver function test things, went back to within normal range, which was 25 to 45. So from 660 to that was extraordinary, you know, in one session, between one lot of blood tests and another. I was still suffering the fatigue though, and I've had to change these antivirals from time to time. This was just as I was starting to regain some energy and feeling, you know, celebratory almost, that, you know, things were getting back to something like normal. It was just then that my routine 6-monthly ultrasound showed a very large tumour had developed on my liver. So it was obviously fast growing because the previous one had shown nothing. And it was the size of my fist, at least. I was immediately sent to Melbourne, to the Austin Hospital Liver Clinic, where they said, the first thing they said to me when they'd looked at the pictures was that it may be too late for any treatment at all. But they said, come back tomorrow because the whole team's having a meeting, and when we meet, we look at all these things. So we'll examine your case and see whether we can offer you anything. But they knew that then already that it was too late for chemotherapy or radiotherapy. Anyway, the next day when I went back, I was introduced to a surgeon. And I remember very clearly because he said he was prepared to operate. And I remember saying, I'm very pleased to meet you, Michael. So that meant, you know, we had to prepare for the operation. And I want to stress something, which is that it was all happening so fast that we didn't really have time to find out a lot about what was happening or to be afraid. I think, you know, a lot of people would expect that you know, fear would be a big part of what you're going through at that time, but it really wasn't, because everything was so rapid. So I underwent a 10-hour plus operation. I don't know exactly how long because I slept through it. And it was complicated by the fact that the cancer had got into my blood vessels. And they did say to me before the operation, we really hope it hasn't, you know, spread out into your blood vessels because that makes things worse. Anyway, evidently it had got there, so they had to remove those too. And another thing was, I didn't know at that time, but back then, the 5-year survival rate for people diagnosed with liver cancer was just 11%. But here I am, 18 years later, and you know, I just feel so lucky. Now, if I've got time, there's a lovely little Melbourne touch to this story, which is that they said it was urgent, that this operation had to go straight away, and that Tuesday was their operating day. And then they said, oh, hang on a minute, next Tuesday's Cup Day, so we can't do it then. So I thought that was rather gorgeous, that it wasn't quite so urgent that it would interfere with the Melbourne Cup. And then the following Tuesday was Remembrance Day. And I remember thinking that may or may not be a good omen. However, the operation went ahead. I have had the most extraordinarily wonderful support from close friends and family, but also the medicos with whom I've had to deal. Really, I couldn't have asked for more, so I'm very happy about that. Whether or not we've experienced stigma because of the hepatitis diagnosis. And I have to say that I hardly ever noticed anything like this. But one time was when I was going through court cases, because this ended up being a work cover matter. My senior counsel, who was a former deputy premier, I have to say, he said to me, well, look, I won't shake hands but because I haven't been vaccinated. And I remember he made sure to keep a table between me and him at all times. And I remember thinking, really, he was a bit of a goose. That was what I thought about that, rather than that I was being stigmatised. But I do remember in the early days when the viral load was high, this was before the antivirals kicked in, that I did have to carry bleach with me wherever I went, so that if I cut myself, I had to pour bleach on blood and all that. So that was a bit, not an actual stigma, but an unpleasant side effect. I think the main one, other than the ones I've already mentioned, were to do with work cover and their insurers, and the 2 court cases that I had to go through to actually prove that this was a work-caused injury. That was an extremely stressful time, and they certainly didn't make it any easier. The distance from Melbourne here, because we're a good, 3.5-hour drive, that entailed a lot of travel, which was much harder when I was really fatigued. I remember one time having to ask the conductor on the train whether I could lie down in the aisle because I was so fatigued. And he said, no, just go up in the first class, those chairs lay back and you're fine. But those sorts of things were a bit of an issue. Getting information has never been a problem for me. But I was talking this over with my wife, and she said, yeah, but you're a white, middle class, English speaker, tertiary educated, think about people who don't have those advantages or those characteristics. So I did want to stress that. I always say to everyone, get vaccinated for hepatitis B and make sure you keep you get the test afterwards to ensure that it's actually taken. I also advise people to trust their medicos, but keep a book. And in that book, you write down any questions that arise for you and take the book with you. Don't be afraid to bring the book out in a consultation. They never mind that. And in fact, I think they think it's a good idea. Also, if you need an interpreter for English, I had 10 lost years really from 1993 to 2003. But I really appreciate being alive, and I'm conscious of all those things that I would have missed had I not had that wonderful surgery. How have things changed for me? Well, I don't drink much because of my liver, but I never was a huge drinker anyway. But and there are other small things. But I think my energy levels now are roughly age appropriate. And looking at the future, well, the present's pretty good, I have to say. And the last 18 years have been a bonus. The future looks good, except that I've now lived long enough to start developing old people's illnesses. And I think that's a privilege, really. And every year I ring the surgeon on Remembrance Day, because it's easy for me to remember to ring him. And I always tell him that now, thanks to his skill, I'm getting arthritis and all those things. So, that's good. My Hep B is still under control of the antivirals. Occasionally there are small issues that require adjustment to do with kidneys and stuff like that, but really I'm healthy and very grateful for the treatment I've had. The interesting thing about those organisations such as Liverwell or Hepatitis Victoria in Australia, as it was back then, and the Cancer Council, was that I wasn't really aware of them until after, certainly after the cancer thing. And I remember thinking that I was so lucky to be spared that I should do whatever I could to assist those particular organisations. And I've done various things from time to time. But those organisations just do the most wonderful work, and I am acutely aware of it. And some of the people I speak to as a volunteer and some of the other work that I do, it just makes me realise what wonderful work's being done. So yes, those organisations, I can't speak highly enough of them.
Thank you so much.
Is it off?
Oh.
When I was diagnosed in 99. Stop.
Thank you so much, David, for your informative video and for sharing your insightful experiences with us. Finally, we are so excited to welcome back the 2021 UCCC winners who were in your very position just last year to share some pearls of wisdom.
All right, hi everyone. Before we start, I'd just also like to begin with an acknowledgement of the traditional custodians of the land. So for us in Melbourne, that is the Wurundjeri people of the Kulin Nation, but we recognise that you may also be tuning in from various places around Australia. So I'll just start with a little introduction of who we are. We achieved first place in the 2021 competition, and we had the topic of increasing HB vaccination course completion in First Nations adolescents. So my name's Amelia. I'm an urban planning and design student. We also have Tish, who last year was doing her Masters of Public Health. She's currently in her final year of med. And we have Nosh, who last year was a final year med student and is now a first year doctor. And just a disclaimer, this is just our tips and tricks. What works for us might not necessarily work for you. We had a different topic. We were a different team with different strengths and skills and knowledge bases. So we don't suggest that you copy our approach exactly, but that you find a systematic approach still that works best for your team and for your issue.
So before you approach the issue, there are a few things we recommend you keep in mind. Firstly, try as much as possible to take a multidisciplinary approach in your solution. It's very important to not only consider the scientific or medical perspective on the issue, but also really considering the psychosocial, public health, design and planning, and project management perspectives. Secondly, be creative, because ultimately you're trying to think of a new and different solution for this issue. So try and think of ways you can approach this in a new and creative way. Thirdly, we came at this competition as a public health case presentation competition, and there are a lot of well-recognized techniques and theory out there on how to approach and structure these kind of case presentations. So, for example, we use techniques such as problem trees, Gantt charts, logic models, stakeholder analysis, evaluation plans. And while we aren't saying you should use these necessarily per se, if you find these techniques are relevant, they really can help make your presentation look more organized and more professional. And we will run through some examples of what we used as we go through.
So step one is the research. So you'll be given, I believe, a case file document by Jacqui, which is a good overview of the issue and a good place to start. But then you have to do a deep dive into the research. So look at the background, look at the like the scope of the issue, the populations affected, and do your research there. And then look into the causes. So look at your barriers and facilitators, and then essentially you're doing kind of a literature search about the epidemiological trends, any data about any community attitudes and norms, information about availability of services, info about priorities of different community subgroups, and any data out there that show why things are certain issues for specific population groups. And then you need to have a look at what's currently being done. So it's important to look at what's being done in like your local community, statewide, and Australia-wide. But another place to also look at is overseas as well, which can be implemented potentially to your program. And then you look at what can be done. So again, look at previous proposals that have been done or investigated, and then see other proposals that are related to maybe other issues that can be translated to your issue, and make sure you're aware of the current infrastructure that exists and whether some of your interventions can integrate well with the structure that's in place. So when we started our research, we decided to use a Google Drive just to keep everything online so everyone had access. So we had Google documents, which had literally everything that we all researched, and we just put everything there. We had all of our references, so we're not losing anything, and we're keeping up to date. And in terms of how you go about the research, you can do a formal literature, as well as searching in the grey literature as well. So formal being looking at PubMed, Medline, and doing key searches in your Google Scholar as well. And then just Googling some key terms in Google search, as well as looking into your local and government sites and any other organisational sites as well.
So based on our research, we then constructed a problem tree. So a problem tree is a diagram that helps you work through the different determinants of health issues and conceptualize how they all tie in together. So we use the barriers and unaddressed needs that we identified from our research to generate these determinants, and then we added arrows between each of these determinants to show how they affect each other. And from this, we were able to create 4 main themes that contributed to our issue. And this is a very visual and messy process, but you need to start messy and then you can clean it up later. And the idea of a problem tree is that once you have identified the main overarching themes of determinants contributing to the issue, you can specifically target these problems in your solution. So as an example for ours, which was about HB vaccination, we found that there is inaccurate record keeping as one of the themes. So we knew that when we went into the design process for our intervention that we wanted to specifically address this.
So step 3 is about applying any relevant public health theory. You will find that there is a lot of theory about how to approach public health interventions, evidence on what works and what doesn't work, and it's a huge field in its own right, and one that you might not be familiar with if you come from a purely science or a medical background. So I would encourage you to try and learn a bit about any relevant public health principles that you come across as you research, and try and apply these in your intervention design. For example, in our case, we spent a lot of time looking into what health system strengthening was, and looking into the importance of community co-design. And then the benefit of doing all this, as well as designing your interventions better, is that later down the track, you can include this theory and this evidence that you've collected. You include it in your slide deck and in your brief, and it helps back up your proposal. Step 4 is your key strategies. So on a similar vein, it's important to consider what strategies you want to employ in your solution. So for example, we agreed that our overarching strategies that we wanted to uphold were sustainability and cultural safety. And we spent a lot of time thinking about how exactly we would incorporate these in all of our interventions. For example, for sustainability, we knew that we would need to make sure our interventions could be integrated with the wider system. And so we knew we had to be really specific about how we would connect and complement with the existing HPV vaccination program.
So now you're up to brainstorming possible interventions, making sure you're keeping in mind the population needs, and also coming from a point of a biopsychosocial point of view. It's also, because you've done your problem tree, it's also important to see where your interventions work in the problem tree and which ones are the most effective. Some of the ways to just kind of think about coming up with interventions is thinking about primary, secondary, and tertiary. So primary being your upstream interventions prior to disease, secondary being interventions for patients at earlier stages of their disease, tertiary being interventions to reduce impact of established disease and disability and improving quality of life. Some examples of interventions could be things to do with the wider population target, so surveillance, outreach programs and screening tools. Other things can be referral and follow-up pathways, as well as case management. Teaching and education is also important, and community-based organised strategies are also good, and some wider picture interventions like advocacy and social media marketing. And then you also need to have a deeper look at your intervention. So is there any research out there that shows its effectiveness, whether it's local or international research? And also have a look if there's any kind of cost effectiveness data to see if it can seamlessly integrate with the current or existing infrastructure. And it's also important to see if it has an acceptability, if your interventions are acceptable within the relevant stakeholders too. So some of them could be your patients, communities, health organizations, and other government bodies. And so now that you've done that, you can either have one very comprehensive initiative or have multiple interventions that comes as like a package, which is essentially what we did. So we had a package of interventions that we tried to complement with the existing infrastructure, and so it doesn't overlap with any existing data or initiative.
And then step 7 is fleshing out your interventions. So you need to be able to design and clearly explain the details of your intervention. You need to be able to convey well what the intervention involves, think about every step / process of your intervention, the what, the when, the where, the how, and the who. So for example, with ours, part of our intervention was we had brochures, we had take-home packages. So actually doing the mock-up, which you can see on the slide here, it really helped us visualize what this process is going to look like. So if you do the brochures, thinking how will you hand them out, where, to who will you be handing them out, and you want to really get your intervention to a point that it's not just theoretical, but can actually get done.
So you also need to be able to argue why your interventions will work. Part of this is first setting the objectives that you want to achieve. So I suggest using the SMART criteria to structure your objectives, that is making them a specific, measurable, attainable, relevant, and time-based. For example, our main objective was to increase HPV course completion rates amongst First Nation adolescents in participating communities to 90% for females by 2026. So really specific and like with a really achievable and specific goal. Then you want to explain the thinking behind why your interventions would work. So for us, we made a logic model, which is this kind of overwhelming looking diagram that helps illustrate how the activities in a program lead to the desired outcomes. Again, not saying you should necessarily do the same. It's up to you how you convey your reasoning, as long as it's clearly explained. From here, the next step is thinking about the nitty-gritty of implementation. So starting with the budget. No one on our team was exactly skilled in finance or budgets, but we did our best, and we considered each of these categories: human resources, equipment, consumables, evaluation, overhead, and contingency. We also thought about things like inflation, so consumer price index increasing from year to year. We made sure to consider appropriately compensating people who were consulted in our project. So for example, making sure that you're compensating the Aboriginal communities that you use in the co-design, because it's not very respectful if you don't compensate them for their time. And then in terms of where to get the actual cost values from, the way we approached it was, as long as we had some evidence from where we plucked the number from and we could back it up, that was all that mattered. So for example, we based salaries off of a salary estimate website and so forth for all the items. Then on to timeline. We used a Gantt chart to depict this, which is a type of bar chart used in project design. But again, however you depict your timeline, as long as it's clearly explained, that's all that matters. We made this using monday.com. if anyone wants to do similar. But some considerations that I would point out in terms of timeline is thinking about whether you'll first have a pilot project, which is a time period where you first launch your intervention in a smaller area or population, and then you evaluate and adapt the pilot project before rolling out to a wider level. And also considering in your timeline, giving yourself time to plan and develop your interventions.
And you could also include an evaluation in your presentation. So collecting data and evaluating your interventions but throughout the whole project timeline. So from your implementation process and your outcome phases of your program. And essentially, you need to think about how you're going to evaluate your interventions and what kind of data points you want to collect to assess their effectiveness. Yep. And another important thing to look at is the inherent assumptions that you've made with your interventions and to explore their limitations. You can also do a risk assessment. So there's a risk assessment table just there. So you can look at the different types of risks with each intervention, look at their impacts and think about ways of mitigating them. And lastly, it's important to think about your stakeholders. So doing a stakeholder analysis allows you to look at all the different types of stakeholders and think about what their main concerns are and whether they have high interest and power to in your program, and how to think about engaging these stakeholders in your program. So an example that we have here for our project was, so one of our stakeholders were First Nation adolescents, and their concern was, could be that like the safety and having a positive experience with the HPV vaccine. And the interest in this program would be quite high, but the power might be medium. And one of the ways that we would try and engage them in our program is to make sure that they're consulted throughout the whole design of their program.
So there's no point of putting all this work into your research and evaluation and timelines if you're not able to communicate your idea well. So you have your 2 deliverables that you are going to have to create. So just as importantly, you spend a lot of time on making these as everything else. So you've got your slide deck. You're going to have a lot of information on it. There's going to be a lot of text, but you want to try to make it, try to add graphics where you can, add visual communications when you can, using things like images and color coding. And you also want to make sure with all that information that the important things are standing out. But when you're using images, you want to ensure that they are appropriate and relevant. So talk a little bit about cultural safety later. But for example, if you're showing things like a picture of people, you want to make sure that that image, what people are actually in that image and what is that saying about the other words that are on your screen. And for the slides themselves, I would recommend using Canva. I'm sure a lot of you have heard of it. It is an online platform that can make you easily create things. It's you can get a free trial for it for a month if you haven't used it before. But the good thing about it is that it has a lot of templates, free templates that you can just use. But if you don't want to use Canva, PowerPoint and Google Slides are also good alternatives. And there are lots of free templates on the internet, and they're just a good starting point. So for your solution brief, you don't have a lot of words for it, and you're going to have a lot to say. I think it's only like 500 words. So it's really important that it's punchy and short, and it makes the judges want to find out more. You want to be arguing for your solution well. So these are the things that we included in brief. We had an intro, we explained the reasoning behind the solution and how we reached it. We outlined our components, the details of the solution, outlined the evidence, the key stakeholders, the key strategies, and the how we're actually going to implement it, including things like the proposed timeline. So obviously you don't need to include everything that we did, adapt it to your intervention.
And some quick general tips. So it's important to make a to-do list and just include literally anything you can think of in your to-do list. create a timeline early and try and stick to your timeline, because I don't think you have much time to get your project together. And it's good to delegate tasks according to strengths. Hopefully you guys are able to group up in different groups with lots of different talents. So make sure you're delegating according to strengths and make sure you meet regularly. And another important thing is cultural safety. So from the outset of our project, we made sure that cultural safety was in the core of our project, from the research component all the way to our presentation. So it's important to be culturally safe in your research, choosing interventions, your design, and as well as your language. I think it's important to know that the inherent power imbalance between knowledge holders, so people who, like us, who are doing the research to make up an intervention, and the general public. So it's always important to make sure that you, when you come up with your intervention, you are thinking of collaborating with the community, and it's community led, because essentially they're the experts and understand the unmet needs. Some culturally safe terms you can use is like culturally and linguistically diverse populations, or First Nations peoples. And so just make sure that you're aware of making sure that your project is very much in collaboration and co-design with the population target. And be aware of the barriers, so things like stigma, discrimination, systemic racism, and understanding cultural accessibility, and making sure you're aware of your patients' rights, and making sure that that is the core of your initiative, and that the whole population feels empowered with your initiative.
Otherwise, good luck and have fun. It's a really fun process and you get to learn a lot. And it's fun working on a project with a team, so enjoy.
Thank you, Leticia, and Amelia, and Inosha for sharing your tips with us. Now that we have heard from all our amazing guest speakers, we would like to welcome any questions for our guest speakers. You may ask your question by unmuting or typing your question into the chat box below. If you wish to remain anonymous, you could also direct message me your question. So we've got some question right now. We got a question for Dr. Yap or Dr. Jacqui. What sort of screening for liver cancer is recommended for people diagnosed with chronic hepatitis B, and also how regularly would you recommend?
I can take that one if you like. So there are liver cancer surveillance guidelines. There is some controversy around the world with regards to the tools that are used. In Australia at the moment, we use a liver ultrasound or abdominal ultrasound, hopefully a liver ultrasound, and the alpha fetoprotein blood test. This is performed, the controversy comes in around the alpha fetoprotein because, as many of you would be aware, this is developed for by the body for a range of different conditions, pregnancy being one. So it's not necessarily very specific to liver cancer. But this is performed every 6 months. And the cancer screening starts with hepatitis B, according to where somebody was born and their age. So Asian-born males above the age of 40, Asian-born females above the age of 50, African-born people above the age of 20, Aboriginal and Torres Strait Islanders above the age of 50, anybody with cirrhosis, and anybody with a family history of liver cancer or cirrhosis are entered into these liver cancer surveillance programs. And this is every 6 months for the rest of that person's life. So I don't think we can underestimate the impact of that screening. And particularly when we're working with people who are from culturally and linguistically diverse backgrounds, where prevention and preventative healthcare and entering into surveillance programs is not, the adherence to that is not high because it's not a part of their health belief system. So I think we can never, I certainly never underestimate that. And there are lots of projects going on around at the moment in Victoria around trying to increase liver cancer surveillance. But we've got to remember that people are often very scared entering into those surveillance programs. Great question.
Thank you, Dr. Jacqui, for your
Just call me Jacqui.
Yeah, sure. We've also got a question for Leticia and your team members. What were some hurdles you came across during the project process?
Yeah, good question. A lot. It was a difficult process, but I think, like, leaning what we said on presentation, just you've got a team, and having 3 different perspectives on like the questions you're facing is a really good way just to get a different perspective. Firstly, in terms of understanding the context of the issue and how you can actually make a realistic intervention that will actually fit in within the system and help and will actually achieve the outcome that you're trying to achieve. Because it can feel, as students, you really don't know what's going on out there, you really don't know the real world, and that's why that research part is really important, and why we broke it down into those steps about, like, really breaking down what are the determinants of the issue, what do we know needs to be done, what is the evidence of what's being done, and then being creative about how you can transfer and apply them. I think the other main hurdles we faced was how to once we'd got our proposal, we had so much information to convey, and how to present that in a way that was really structured and got all the information across within the limited amount of time. And that's where design really came into play, and Amelia was our chief designer. She made all our slides look pretty and our solution brief look nice and punchy, and conveyed the information in a way that was really understandable, and that's really important. And then I think probably the other main hurdle that we faced was the time management, because it's a lot to get done, and I know you guys are all busy students. So create a to-do list, delegate tasks, and like turn it into a fun friendship forming little exercise where you guys meet up over Zoom or whatever and work on your project together. Use it as a break from all the boring, you know, MD1 lectures or biomedicine or science or whatever you guys are doing. Anything to add, Amelia or Inosh?
No, I think you did you answered it quite well.
Thank you. And we've also got a question for Chloe. They were wondering what initiatives has Liverwell come up with and try to action that has not been successful or have not reached their target population.
That's an excellent question. I think one of the examples that I could use would be our attempts at regional forums. So each year we run 2 or 3 regional forums in regional Victoria. And last financial year, we had less people attend than what we would have liked to have done. And I think one of the key things that we needed to do, and Leticia and Amelia and Nosh have highlighted this, was engaging with community and engaging with the stakeholder groups, because they know where the unmet needs are. And it's just really great to hear that perspective and have that drilled down, because even for us, like, making assumptions about what the unmet needs of communities are is really challenging. And if we'd engaged with those communities, we probably would have had more backsides on seats per se. So that's probably one of the examples of a strategy that didn't work, but we've certainly learnt from that, and we're implementing community engagement as we move forward.
Thank you, Chloe. And we also got another question in the chat box. With the current outreach program used by Liverwell, have you guys been able to evaluate where the main number of users are from? Like, let's say like English speaking background-ish? Yeah.
So we've got a number of outreach programs that we use. In our liver line, we see a lot of people from high endemic regions, so Southeast Asia, Sub-Saharan Africa, Australians, so migrant populations calling in. In terms of our outreach program for workforce, it's a real mix of people that we see coming in. In our community education for CALD populations, culturally and linguistically diverse populations, our Vietnamese, Chinese and Cambodian populations are probably the biggest areas where we focus there. And then obviously you've got the people who inject drugs, we have the people who are experiencing homelessness, and I could just sort of rattle off all of our priority populations as I answer this, but yeah, there's no one typical hepatitis patient, and there's no one typical cancer patient. So obviously there's endemic regions and higher prevalence populations, but we get such a mix. It's really interesting.
Thank you, Chloe. And we got a question for David in chat box as well. How has the regular screening impacted you? Hi, David. I think you are muted.
There it is.
Yep.
It would, the touch screen wasn't working. Look, I'm lucky in that because of the illness that and the fatigue situation, I haven't been in full-time work for many years now. Of course, I'm retired. So for me, it wasn't such a big burden. But for people who are working very hard and you know, have maybe further away. I'm 20 kilometres from the nearest hospital where I can get an ultrasound and stuff like that, get an AFP test or whatever. It hasn't really impacted me terribly much, except that especially in the first few years, you're pretty anxiously awaiting the results. Does that answer the question?
Yeah, well, I think it's a really good answer to the question. And we've also got one more question for Jacqui, Dr. Jacqui. Yeah. Can we develop a shared care model for treating viral hepatitis in the community?
That is what I've spent most of my career trying to do. So if you can get one that works, I'll be sort of slightly depressed, but also slightly enthusiastic and motivated, because if you can make it work. So for years I have worked in Royal Melbourne Hospital, St Vincent's Hospital, and now affiliated with the Alfred Hospital, but particularly St V's and Royal Melbourne, to try and remove patients from liver clinic and get them to be cared for by their general practitioner. So that would involve me going and setting up systems through the patient management systems. It would involve teaching the GPs about what to do, really supporting a whole of practice approach to quality improvement and making, hepatitis B or hepatitis C a part of that. And also obviously educating the patient. One of the things that I did in early 2011, 12 and 13 was actually speak to patients and identify those who were suitable. They weren't on treatment, they were just being monitored. They could easily get that care at their general practice. And I was fairly terrified by the high number of people who attended the liver clinic every 6 months, had done so for decades, and had no idea why they were there. They thought there was something wrong with their liver, but they weren't quite sure. The doctor just kept telling them what to do in terms of keep coming back. So as young doctors in the making, as young scientists, I think you need to recognise the power that you have over people, and you have an incredible responsibility to ensure that people have some ability to self-manage. And that is really, really important. Some people are very, very motivated and really, they know exactly what's going on. People like David, who've got their little book, which I love. Whenever a patient brings out a little book with questions, I go, fantastic, because I've got somebody who's engaged here. But there are many others who want to just sort of externalize that control. So shared care is really hard for, I hope some of the doctors in this audience decide to go and do general practice. We really need you in general practice. But we also ask a lot of our general practitioners, but there's lots of support systems in place that we can definitely support shared care. I don't think we use technology well enough in Australia. We don't have a shared medical record like they do in other parts of the world, which really does support that. So if there's any IT gurus on the line, that is a great challenge as well. That we could, I went to Christchurch, the whole place was destroyed by an earthquake, and they took that opportunity to rebuild the system. And it is remarkable what they've been able to do there. So shared care is absolutely the way to go, because we build capacity while caring for the patient in a more person-centered way, closer to their home, not paying $25 an hour for parking. Can you tell I'm slightly passionate about that topic? I will put myself on mute right now because I could keep going.
Thank you so much for that answer, Jacqui. David, did you have something to say?
Yeah, look, I'm really interested in Hep B vaccination rates and what are the problems with, are there pockets of areas not being reached with, I think children in schools now are, anyway, what's the take up and where are the problems with that?
Yeah, it's a really, really good question, Chloe. I'm not sure whether you want to take this as well. We've got national targets, obviously, around hepatitis B vaccination, and we are very high. We're about sort of 98% for infant immunisation, which is fantastic. But it does drop off for people who weren't born in Australia. Obviously, there's been arguments. Deputy Chief Health Officer, Professor Ben Cowie, has argued that our public health dollar would almost be better spent vaccinating our geographical region so that people who don't have access to the Hep B vaccine would get access. Certainly there's people who have incomplete vaccine schedule and, we're seeing that a lot across the board at the moment with COVID, obviously. This is a 3-course vaccine. So there's the anti-vaxxer movement, of course. And fears around Hep B, which have been Hep B vaccine that are unfounded and have been repeatedly shown to be false, and they were falsified. But there are certainly people out there who still choose not to be vaccinated, and there are people who just don't know that they're at risk, so they don't come forward.
And there's a generation of people like myself who didn't have the at-birth vaccine doses and potentially missed out on childhood doses for whatever reason, and don't know that they need to be vaccinated as an adult. And that's anyone born before 2000, roughly. So that's a huge amount of people.
Yeah, Chloe, it's such a good point too. And even there's lack of equity between the jurisdictions. So we had a catch-up program for Year 7 students And that went for a number of years. In Victoria, the vaccine was administered in schools. So kids quickly figured out, oh, well, if I skip school that day, then I won't need to have that vaccine. In New South Wales, they said, they put it onto the parents and they said, your children have to be vaccinated and you need to take your child to the vaccine. So if you don't have bulk billing and if you don't have an after hours practice, then all of a sudden you've got multiple barriers in front of you as well. So yeah, Chloe, it's an excellent point.
Yeah, absolutely.
Yep, and also one last question. It is a question for the panel. Do you guys have any suggestions for how to prioritize and work around the practical constraints of the case? For example, the budget.
If we got $10 million to do anything in hepatitis, we would be beside ourselves. We would literally be beside ourselves. It's the most thing. And this is where we're the poor cousin to everybody, because we look at $10 million, don't we, Chloe? And we go, oh my gosh, imagine what we could do. It would be like Christmas. Because we've got it. And, you know, I really take Leticia and Amelia and Osha's point about that multidisciplinary team, bringing champions together from different areas. Creating structural change is very, very difficult. And it is very, very expensive, obviously. But Chloe.
I was going to say we're not a sexy organ. So
no,
a lot of that budget is probably going to be allocated to marketing and communications. And I think that's probably one of the key challenges that we have as well. It's getting the word out there about how important your liver is. It's not an ovary, it's not a breast, it's not a sexy organ. So,
but without it,
you can't
live very long.
No.
Thank you. I think that's a really good point. So thank you to our panel for answering all those amazing questions and for everyone for submitting them. If you have any other questions that you think of from now until the end, till submissions, feel free to email them to us, feel free to Facebook message them to us, and we can distribute them out to ask our amazing guest speakers. So finally, before we end, I'd like to briefly clarify the dates and logistics of UCCC for this year. So coming up next week on Monday, we've got our Basic Biology of Cancer workshop. So if you're a little bit overwhelmed tonight and you don't know all that much about cancer, this would be a great workshop for you to attend. It is just 1 hour and it'll give you the basics of how cancer happens, some treatments with a focus on liver cancer and hepatitis. And it's a chance for you to ask all your questions and things that you might not have understood from tonight. Then on Wednesday, we have a slide making workshop and it will also involve a bit more of what Amelia and Leticia and Inosha were saying about being able to pull apart the problem, create some of those problem trees. So we'll have Hilary from NOUS to help you work through all of that. As you're probably aware, the deadline for submissions is coming up. So that's on Monday, the 29th of August, and submissions need to be submitted by 5 p.m. And you'll find lots of details about the submissions in the case guidelines. So you'll need a 15-slide PowerPoint presentation and 500-word overview report. On Monday, the 12th of September, we'll have a very exciting finalist announcement. And then those finalists will be invited to present their solution to our panel of judges who you've met tonight on Monday, the 19th of September. And on that night, we'll crown our UCCC finalists for the year. So all the case guidelines and case file are now posted. They're on our website. They're also on the Facebook event. And if you could remember to fill out the evaluation survey as well, that would be amazing. And we'll draw that raffle tonight.
Yeah, so we hope that you guys have found tonight very informative and now have some ideas on your proposed solution to increase diagnosis and treatment of liver cancer. We'd like to thank all of our guest speakers. Thank you so much for your contribution to UCCC this year, especially all of you from Liverwell for helping us out throughout this whole process. And we're really excited to see all of your proposals and meeting again on finalist night. Thanks, everyone.
Thanks, everyone.
Thank you.